Hello everyone, my name is Victor Olujobi and today I'll be presenting an overview of approach to abdominal pain in pregnancy. I'll be addressing this topic by looking at an introduction, a categorization of abdominal pain in pregnancy, changes in pregnancy that contribute to diagnostic dilemma of abdominal pain in pregnancy, as well as etiology and differential diagnosis, abdominal trauma and pregnancy, investigations including abdominal imaging in pregnancy, a rational approach to management, as well as surgical options. Abdominal pain is the most common complaint in pregnancy, and appendicitis is the commonest cause of acute surgical abdomen during pregnancy, followed by cholecystitis and bowel obstruction, which is mostly due to adhesions and volvulus. Up to 50% of abdominal pain in pregnancy have no identifiable pathology. The origin of abdominal pain in pregnancy can be uterine, extrauterine, or extra-abdominal. The goal of any evaluation is to promptly identify the pregnant women with serious or life-threatening etiologies. Abdominal pain in pregnancy is categorized into physiological and pathological, and the pathological category is further subdivided into obstetric and non-obstetric, while the non-obstetric arm is subdivided into surgical and non-surgical or medical causes. The diagnosis of abdominal pain in pregnancy is rendered challenging by the following factors: the relative frequency of pain, as well as nausea and vomiting during normal pregnancy, modified response to peritoneal irritation due to the presence of pregnancy changes, the presence of the expanding gravid uterus and its activity, the presence of a fetus, and changes in the usual position of some abdominal viscera. The anatomical changes in pregnancy that modulate abdominal pain in pregnancy includes the following: the rapid expansion of the gravid uterus usually results in the stretching of the supporting ligaments of the uterus, especially the round ligament, and this is responsible for physiologic pain, which occurs in 10 to 30% of pregnant women. Physiologic pain from round ligament pain stretching is a diagnosis of exclusion. There can also be the displacement and compression of some intra-abdominal organs. For instance, the bowels, the stomach, and the omentum are usually displaced cranially in pregnancy. This usually leads to the classic presentation of appendicitis in pregnancy being altered. Also, the gravid uterus might shield the peritoneum of the anterior abdominal wall from irritation, and peritonitis might therefore not be readily elicitable early. A failure to recognize this altered presentation may result in delayed diagnosis, thereby leading to an increase in maternal morbidity and mortality. The following image shows the abdominal quadrants, and their anatomical relations. Pain or tenderness in a particular quadrant might point to the possibility of pathology in the underlying viscera. Please take a look. The following table shows cardiovascular, hematological, as well as respiratory changes in pregnancy and the respective implications. In terms of the differential diagnosis of abdominal pain in pregnancy, certain obstetric causes are gestation specific. In early trimester, obstetric causes of abdominal pain in pregnancy will include miscarriages, molar pregnancy, ectopic pregnancy, ovarian cyst accidents, including rupture, hemorrhage, or torsion, complications of invasive procedures during pregnancy, stretching of the round ligament and pre-existing abdominal lesions, acute urinary retention, as well as fibroid degeneration. In later pregnancy, the causes of abdominal pain will include contractions, placental abruption, uterine rupture and impending scar rupture, liver pain from preeclampsia, HELLP syndrome, and acute fatty liver of pregnancy, pressure from polyhydramnios, chorioamnionitis, musculoskeletal pain, usually from pubic symphysis diastasis, as well as fibroid degeneration. The non-obstetric causes of abdominal pain in pregnancy could be surgical or non-surgical, and the surgical causes will include appendicitis, biliary disease, pancreatitis, peptic ulcer disease, acute mesenteric infarction, bowel obstruction, ureteric obstruction, ruptured aneurysm, or neoplasm. The non-surgical causes will include urinary tract infection, inflammatory bowel disease, ovarian cyst accidents, trauma and assault, constipation, pneumonia, psychogenic causes, and some medical causes like myocardial infarction, diabetic ketoacidosis, and porphyria. The causes of abdominal pain that can be exacerbated by pregnancy are the following: heartburn from gastroesophageal reflux, gallbladder disease, urinary tract infection, musculoskeletal pain, stretching of abdominal muscles, particularly at the attachment to the ribs, and pregnancy complicated with sickle cell crisis. Abdominal trauma in pregnancy can be blunt or penetrating, and the most common causes include road traffic accident, intimate partner violence, and falls. Depending on the community where the women live, physical violence affects at least 10% of pregnant women, and inquiries about this should be carefully made while attending to women with trauma. Complications will depend on the severity of the trauma, but placental abruption and uterine rupture are serious complications, with uterine rupture tending to occur more with advancing gestation. Fetal losses up to 70% have been reported, and this is mostly due to placental abruption, maternal shock, and maternal death. The mechanism of placental abruption is usually due to sudden acceleration-deceleration forces. At least a 24-hour observation period, including cardiotocographic monitoring of the fetus, should be done if the fetus is viable. The Kleopatke test should be performed to identify fetal-maternal hemorrhage in rhesus-negative mothers, and appropriate dose of anti-D immunoglobulin should be administered intramuscularly. If cardiopulmonary resuscitation is required, a 25-degree left lateral tilt of the patient with manual uterine displacement should be performed. After a cardiac arrest, perimortem cesarean delivery can improve neonatal maternal outcomes. A systematic and rational approach to management of abdominal pain in pregnancy is essential. It is crucial, therefore, to document any adnexal pathology during dating scan, as well as any pre-existing medical and surgical conditions in the patient's maternity case record. One should, however, suspect a pathological cause for the abdominal pain if a high dose of repeated analgesia is required for a presumed non-pathological abdominal pain in pregnancy. It's important, however, to keep in mind that young, fit, pregnant women usually compensate well initially, and that though the pregnant women may compensate, the fetus usually does not do well with hypovolemia, and pathology might be missed if this is not borne in mind. Pointers to serious pathology are moderate to severe pain, vomiting, fever, new hypertension, hypotension, recent trauma, and vaginal bleeding. A multidisciplinary approach might be required depending on the specific diagnosis. Approach to management of acute abdominal pain in pregnancy. The initial step in the diagnosis and management will include a detailed history and focused physical examination. Symptoms as well as the location of pain will point to possible pathology in most cases. The next step is to use diagnostic tool to aid clinical assessment, and then to assess hemodynamic stability. If the patient is unstable, urgent resuscitation and urgent critical care should be commenced, and surgical consultation, if required, can be arranged. A bedside abdominal ultrasound is valuable in diagnosing most of the abdominal pathology. Fetal evaluation should, however, only be done after the pregnant woman has been stabilized. Urgent surgery is indicated if abruptio with a live baby or uterine rupture is diagnosed. If there is a sustained improvement with resuscitation, a trial of conservative management might be considered depending on the specific diagnosis. However, conservative management of appendicitis in pregnancy is not recommended, as it is associated with miscarriages, and preterm deliveries. Urgent surgery is indicated if there is peritonism, hemoperitoneum, or pneumoperitoneum. If the patient is stable, the approach will be to determine the abdominal quadrant involved, as well as the possible differential diagnosis. If the pain is in the right upper quadrant or epigastrium, the possible differentials will include acute appendicitis, gallbladder disease, liver disease, like HELLP syndrome, acute fatty liver of pregnancy, hepatic rupture, and hepatitis. Other differentials will include pyelonephritis, pancreatitis, gastritis, and gastroesophageal reflux disease, and pneumonia. In the right lower quadrant, the possible differential diagnosis will include salpingitis, ureteric colic, adnexal torsion, bleeding and rupture, uterine rupture, and appendicitis. While in the left upper quadrant, the possible pathology could be gastritis, pancreatitis, hepatitis, splenic artery aneurysm, myocardial infarction, and pneumonia. The differential diagnosis of pain in the left lower quadrant will include ureteric colic, ruptured dissecting aneurysm, bowel obstruction, adnexal torsion, and uterine rupture. The differential diagnosis of diffuse abdominal pain in pregnancy will include peritonitis, including appendicitis. Other differentials will be bowel obstruction, sickle cell crisis, mesenteric artery thrombosis, gastroenteritis, colitis, and leukemia. If the patient is stable, further investigations can be carried out and a firm diagnosis made. Plain chest and abdominal radiograph can be carried out. However, radiographic imaging should not be withheld because of the fear of exposure of the fetus to ionizing radiation, and I'll be discussing that in subsequent slides. Ultrasound-guided drainage of abdominal collection or pigtailing can be considered if amenable, and surgery should not be delayed in the face of peritonism, hemo or pneumoperitoneum, and intra-abdominal sepsis. If the patient is stable and the condition is considered non-urgent, a close monitoring is required and further investigations can be carried out, with the cause of abdominal pain categorized and appropriate management or consultations instituted. However, if there is improvement with the trial of conservative management in certain cases, definitive postpartum elective surgery can be planned, but urgent surgery must be done if there is relapse or failure of improvement with conservative management. Imaging in pregnancy. Ultrasonography is the first radiological modality of choice for the evaluation of acute abdominal pain in pregnancy. It is available, usually, it's portable, non-invasive, and lacks ionizing radiation. It has a high sensitivity and specificity in diagnosing common abdominal pathology. However, its efficacy declines after 32 weeks of gestation owing to abdominal space limitation as well as the compression of abdominal structures by the growing uterus. Magnetic resonance imaging is the second radiological modality of choice. It provides excellent soft tissue imaging and also lacks ionizing radiation, but it is, however, not readily available. Radiographs and computerized tomography scans with or without contrast agents can also be used. There is, however, the concern about the harmful effect of ionizing radiation in pregnancy, as the developing fetus is sensitive to the effects of ionizing radiation at certain radiation dose. The risk factors for fetal harm following radiation exposure are the following: the cumulative radiation dose, as well as the gestational age at exposure. The greatest risk of embryonic mortality is usually during the first 2 weeks of gestation, with the all or none effect. And the most vulnerable period of central nervous system teratogenicity is between 10 to 17 weeks. In late pregnancy, however, the concern shifts from teratogenicity to the risk of childhood malignancy. According to the American College of Gynecologists and the American College of Radiologists, the risk of radiation-induced fetal harm is negligible at a radiation dose of 50 milligram or less, and the risk of malformation is only significantly increased at a dose greater than 150 milligram. According to the International Commission of Radiological Protection, fetal radiation dose less than 1 milligram is not significant, and counseling is not required. Plain radiographs deliver negligible amount of radiation, especially when the fetus is not in view. The fetal dose of radiation with a 2-view chest radiograph is less than 1 milligram. Because a computerized tomography scan delivers collimated dose of radiation, radiation exposure is negligible if the fetus is not in view. Routine computerized tomography scans of the abdomen and pelvis delivers a fetal radiation dose of about 25 milligram. Radioisotope imaging can be safely used in pregnancy for ventilation perfusion lung scans, and the fetal exposure to radiation is usually less than 5 milligram, and technetium-99m is the isotope of choice during pregnancy. The surgical options can be laparoscopic or by laparotomy, and the management of acute abdominal pain in pregnancy follows the same principle as in non-pregnant cases. Open laparotomy has been traditionally preferred surgical intervention in late pregnancy, with premature labor being a common complication of surgical interventions in late pregnancy. Recent evidence, however, suggests that laparoscopic surgery compares favorably well with laparotomy in terms of safety and efficacy where indicated. If the diagnosis is in doubt and laparotomy is chosen, a midline incision is recommended, but with minimal manipulation or handling of the uterus as surgery. Laparoscopic cholecystectomy is the most commonly performed laparoscopic surgery due to acute surgical abdomen in pregnancy, followed by appendicectomy. And this surgery is preferably performed in the first and early third trimester. But if the patient is unstable or unwell, surgery can be performed at any time. Transvaginal ultrasound assessment of fetal well-being is ideal during a laparoscopic surgery, and fetal heart rate monitoring before and after surgery can be an option. The concerns about the safety of laparoscopic surgery in pregnancy will include the risk of trocar injury to the gravid uterus, technical difficulty due to limited space, and concerns about the adverse effects of carbon dioxide insufflation. Fetal acidosis, tachycardia, and hypercapnia have been reported in animal studies. At an insufflation pressure of 8 to 12 millimeters mercury, there is a reduced risk of placental hypoperfusion and maternal pulmonary events. In summary, abdominal pain is a common complaint in pregnancy. Abdominal pain in pregnancy can be broadly classified into pregnancy and non-pregnancy related causes and requires a systematic diagnostic and therapeutic approach. The gravid uterus with advancing gestation will usually displace abdominal viscera and alters the classical clinical presentation of abdominal pathology. Physiological and biochemical changes can interfere with the interpretation of certain laboratory results. Acute appendicitis is the commonest surgical cause of acute abdominal pain in pregnancy. The conservative management of acute appendicitis in pregnancy is not recommended. Life-threatening obstetric causes will include ectopic pregnancy, placental abruption, and uterine rupture. Ultrasonography is the recommended first imaging modality of choice in the evaluation of abdominal pain in pregnancy. When indicated, contrasted radiograph and computerized tomography scans can be performed after adequate counseling. It is important not to delay surgical intervention in the presence of acute abdomen. The following are my references, and thank you for listening.